everyone, I'm Dr. Ali Bozorgi, cardiac electrophysiologist, and very welcome back to ECG Refresher Part 11. Today, I'm presenting a 72-year-old male with history of CABG 10 years ago and dual chamber pacemaker implantation last year due to complete heart block. He presented to the emergency room with complaints of persistent fatigue and dizziness over the past month. Bedside echocardiography revealed an ejection fraction of 30%, moderate mitral regurgitation, and no pericardial effusion. Now, let's closely examine the patient's ECG together. I encourage you to pause the video, carefully analyze the ECG, and in a few minutes, I'll provide you with an in-depth breakdown of what we are seeing. As mentioned earlier, the patient had a dual chamber pacemaker. The expectation with a dual chamber pacemaker is that in patients with a normal SA node, the device should recognize and sense the P waves. It should then pace the ventricle after a preset interval. In cases of sick sinus syndrome, both atria and ventricles should be paced. However, in this case, we observe P waves not being tracked by the pacemaker. Simultaneously, there are atrial spikes that do not result in the atrial capture. Here, you can see P waves that's not sensed by the device, and there is a spike, atrial spike, that's not resulted in P wave. After a preset AV interval, ventricular pacing and capture occur. Actually, the device functions as a single chamber pacemaker. A chest X-ray revealed atrial lead dislodgement, but why the patients become symptomatic despite good ventricular pacing? The answer lies in pacemaker syndrome. Historically, early pacemakers were single-chamber devices that paced the ventricle in isolation. This could lead to poor coordination between atrial and ventricular contraction, resulting in reduced cardiac output. Pacemaker syndrome may occur due to atrial contraction against a closed AV valve or atrial contraction occurring too close to ventricular contraction, causing back pressure in venous system. This can manifest as fullness in the neck, a resultant Canon A wave in JVP, and also pulmonary congestion causing dyspnea. Loss of atrial capture resulted in decrease of cardiac output as well. Symptoms of pacemaker syndrome include neurologic symptoms such as fatigability, memory loss, confusion, and transient blackouts. Cardiovascular symptoms may manifest as low blood pressure, exertional dyspnea, orthopnea, palpitations, and a decrease in exercise capacity. Hemodynamic signs include prominent neck pulsation, abdominal pulsation, and right upper quadrant pain. The treatments for pacemaker syndrome involves upgrading the device to a dual chamber system, or in our case, re-implanting the atrial lead in the proper location. And that's all for today. In summary, we have a case of undersensing of P wave due to atrial lead dislodgement that makes the device to pace just ventricle and causing pacemaker syndrome. For more details on this case, please visit cardiocase.com and read case 585, elaborated upon by Dr. Samaneh Mohammadi. Stay tuned for our upcoming videos where we delve into more ECG insight. Thank you for watching and joining us, and until next time.